Thank you. I hope that the conversation we're about to have with some of the people at the table here generates an avalanche of questions. We have an opportunity this morning to hear the perspectives of some people who bring expertise to this field, that is the presumed consent, opt-out, and or an opinion, or both. And this is a chance, I hope, to hear in a short summary what their perspective is through their particular lens. But then what I really hope evolves is a bit of a two-way conversation between the people here and people in the audience who might have specific questions that they've been wondering about. We're going to try and sort of do this in an unofficial order where Aimee Sarti is going to be talking a little bit about her work around donor families. Jennifer Chandler is going to talk about legal issues related to opt-out. Linda Wright is going to be talking about some of the ethical issues that may present themselves around this. And then Cynthia Isenor, who many people know through her work in Trillium, has been a godsend for us in Nova Scotia. She's the administrative lead for us, and she may very well be able to provide more in details on the practical operational challenges that we're facing as we bring this forward. So having bumped into the next hour because of whatever, we'll get started. And so, Aimee?
Thank you, and thanks so much for the opportunity to be here. As many of you know, right now with our group, we are leading a national study of family members' experiences in the current system across Canada, and have really had a great opportunity to hear from family members about what their experiences have been like through the ICU. And I think as I was really reflecting on this system change, I think at the forefront, and obviously I'm here to talk about maybe some impacts that this could have on family members, I think it's really important to remember that there's certain things that, regardless of the system, I think are going to always be important to family members. And having their loved one cared for in an empathetic way, their values and their wishes respected, having great communication from the team within the hospital, these are things that are not going to change, and we need to remember that. And then when I look at things, it's really interesting to hear from Phil and the experience and the potential positives that could come out of this, but then also to reflect on potential negatives that could come out of this and really have a clear and careful discussion around that. And when we look at what may come of this from a public perspective, I think one of the potential positives is increased dialogue around organ donation. And we do know from literature and from our work that supports also that if family members have had a conversation with their loved one beforehand and have already known their wishes, that decision becomes easier for them in a moment of absolute crisis and tragedy where their state of mind and having to think through these things can be really difficult. So I think that dialogue in the public beforehand could be a very big positive. And the other piece that was already really highlighted well, I think, is the system change. And if there's a system that can better support family members through seeing the wishes of their loved ones fulfilled and supporting them through this difficult time, I think that could have a tremendous impact on their experience. That being said, I think Phil also alluded to that conversation in that moment can be done wrong, and if we have a conversation with a family member that isn't based on their loved one, or is challenged by the legislation, or if the public view or social media portrays things that bring people's fears into the ICU in other ways, I think that could certainly have a negative. And it's important for us to kind of look at both of these sides. The other piece, and we're very fortunate to have partnered with the group as well to be able to evaluate and explore family members' experiences in an ongoing way. And part of what we are intending to do is to look at the family member experience before this whole package has been rolled out, and explore what has happened after. And have there been changes? Have there been positives? Have there been challenges from a family member's perspective that are different? So I think that ongoing engagement with family members and their experiences is really critical.
Thanks so much, Steve, and thanks very much to the organizers for the opportunity to speak to you. It's frankly a very good thing I'm going second. It's given me a moment to recover from hearing that Steve's not particularly interested in the law. As a, as a lawyer, I just, my blood ran cold there for a minute. So I thought what I would do is, I'm speaking as a lawyer here and giving you some legal reflections on presumed consent. And I thought I would talk about two things. First, one of the ethical issues around presumed consent has been, can we really actually presume the consent? What do we do where we have reason actually not to presume the consent? So it may be that in the population at large, we know that there's majority support for organ donation, and this gives us a foundation for presuming people's consent. But we also are on notice that there's certain subpopulations that actually are more likely to object to consent. So this might, to donation rather. So it might be some ethnic groups, some cultural groups, some religious groups who may have particular reasons that tend to cause them not to want to donate. So, whether this is a function of objection to the removal of organs if one views oneself as not having the right to dispose of them because it's gifted from the Creator, or a need to continue on intact into the afterlife, this might be a reason to object that is associated with a particular cultural group. Or there may be an objection to brain death. We know that in Ontario very well from the recent McKitty versus Isenor case. Or indeed an objection to practices around withdrawal of life-sustaining treatments. So what do we do if we are actually on notice that some groups, perhaps our presumption is not actually well-founded? Now, drawing on from the recent McKitty versus Isenor case, it seems that it may be a presumed consent regime or opt-out regime might be challenged on the basis that it does call into question people's religious freedom. Now, you might say to yourself, well, if you're objecting to organ donation, or I should say, if your objection is based on brain death, for example, that is not an objection to organ donation, it's instead an objection to brain death. So in fact, it's not an infringement of religious freedom to presume consent to donation. And I would suggest that I think that, point taken, but there's also a sense in which we have this kind of expansion of religious or conscientious objection, and this takes place indeed in the organ donation context. So if you look at a policy statement from Canadian Society of Transplantation, talks of conscientious objection by physicians to caring for people who've purchased an organ illegally abroad. So this is an example of objecting to sort of the downstream sort of associated consequences of an act that's objected to. So it may be, by analogy, that families might object to what flows from the impugned immoral act or disputed act, the declaration of death on neurological criteria. So all this to say, I can see a way in which a family might raise a challenge on religious grounds to a presumed consent regime, and one would then switch into the question of, well, is that sort of limitation of religious freedom justified under the Charter of Rights and Freedoms? And the question there would be the importance of the government's objective in putting in place a presumed consent regime, and also the extent to which that religious objection is being accommodated reasonably. And in a presumed consent system, you could say, yeah, there's a variety of different accommodations for religious objection here. One is you can opt out. It's not as if we're conscripting the organs. And secondly, even if we're concerned that the opting out is for some reason not going to be accessible to some people from literacy reasons or linguistic reasons or other reasons, we have also the consultation of the family who can bring to bear that information about the religious objection. Now, we do have some difficult points here, because what if there is no substitute decision maker really available? At what point then are we justified in going ahead with a donation from someone from a community that we expect is more likely than not to have an objection to donation? This becomes murky and I think could raise some sort of legal issues. Furthermore, in terms of assessing the reasonableness the accommodation of objection, you have to ask yourself questions about how burdensome are the opt-out procedures, for example. And this will be a function of how much information is provided to the population about it, and also what procedures need to be followed. And even then, there may be some constituencies for whom it will be unreasonably burdensome to have to opt out. If you think, for example, about undocumented or illegal immigrants who are going to be nervous about putting themselves onto some sort of government registry. Now, you can see that I'm raising all kinds of sort of small, niche, minority kinds of issues, but nonetheless, they do exist and potentially may come up. So the second topic I wanted to raise, and I'm going to chuckle at Steve again here, because when we were having a little chat earlier to prepare for this, he said, you know, Jennifer, like, you lawyers, you're the only people who care about pre-mortem interventions. Families don't care. It's always you lawyers, right? And so we were kind of chuckling a little bit about that. And it made me think of one of the families that I interviewed in organ donation. It was a small study that Aimee and I have been working on with families as well. And a mother who said to me when I asked, so you consented to donation for your son? And she said, well, hell yeah, I don't care what he thinks. I'm not letting my son selfishly take his organs to the grave, I think she said. And it made, again, my lawyerly heart skipped a beat or two, because that is not what a substitute decision maker should be doing. Should be reflecting what the directly expressed or understood values and beliefs of the patient. So it's for that reason I get a little bit nervous about how we handle presumed consent and, pre-mortem interventions. So the question that comes up with presumed consent is, we may be presuming consent to donation, but what's included in that? To what extent are the kinds of interventions and or changes to the normal way of proceeding with a dying patient in the DCD context included or implicit in that presumed consent to posthumous donation? And I mean, it could be all sorts of things: changes to location, timing, procedures of withdrawal, pre-mortem testing of various types, from invasive to not particularly invasive, various surgical preparations, art lines, and so forth, drugs, heparin, and so forth. And at least if we have a system where consent is being sought from the SDM for these, we have some sort of, we have a different kind of discussion. We can decide what's going to be included there. If there is not necessarily going to be that kind of discussion with the family, then we have to have a slightly different thought about what is going to be included within the presumed consent to posthumous donation. Now, I think in Nova Scotia, this is not so much of an issue, because Nova Scotia is very unusual in having explicit legislated provision regarding pre-mortem interventions. Indeed, it's necessary to get explicit consent. But in other jurisdictions, as other provinces go forward, we don't have those particular specific rules in our organ donation legislation. And there will need to be a question about, okay, well, how much extra stuff do we get to just go ahead and do to the still living patient when we're presuming consent to posthumous donation only? Again, ultimately, maybe this is not going to be a huge issue all the time, because most of the time families will be present, there will be discussion and so forth. But in those instances where a family member is not present, it will be an issue.
Thank you. And Linda now will take the stage.
Thank you. So I'm going to presume that everyone cares about the ethics. Personally, I opt in. I want to start by just talking about the words we use and the terminology. I think it's really challenging to say that we presume anyone's consent on anything. I'm much more comfortable referring to this as an opt-in or an opt-out program, and I'm not just being sort of pedantic about it. I think the words do shape our thoughts, and in some cases there are people who will react in a negative way to us using the terminology of presume. However, that has been used, and we see it in the literature. From an ethical point of view, I consider organ donation to be a social good. It saves lives. It's something that I believe we should all consider. I would go so far as to say it's a responsibility. That's a word that's not used a great deal these days. We tend to focus more on rights than on responsibilities, but that's the way I personally see it. So some considerations in terms of us using an opt-out system as opposed to our current opt-in is that certainly it's been used in many parts of the world in very different ways. And it's hard for us to compare the statistics that come out of those because of those differences in how it's implemented. But it has not certainly satisfied the organ shortage in all the places where it has been brought in. And I think we have to learn from those other places as to what exactly they did and how we may or may not want to adopt the things that they have done. And of course, different populations will react in different ways to different measures that we bring in. In North America, we tend to value very highly individual decision-making. We're heavy on autonomy, on us having the right to make decisions about ourselves, which is not the case in every part of the world. And so I think we have to tread very, very carefully in terms of introducing a system that says unless you have registered a wish not to, that we're going to assume that you want to do this. In terms of the implementation, it's been very interesting to hear about what's happened in Wales and also what's being planned in Nova Scotia. And I understand now that a bill has been introduced in Alberta, also looking at potentially presumed consent. Any mechanism that we would have for registering a wish not to donate would have to be very easily accessible. And that's more easily said than done. But I think that that's important, that people see it as something that is not too onerous to do in case they don't want to have their organs donated. Public information, we heard from Wales, has been challenging. It's very difficult to do. We speak to public health professionals and they'll say, how do we persuade even healthcare professionals to get a flu shot, for instance? It's staggering how many do not do that. It's very difficult to get information over to the public in a way that that will get a lot of uptake and where they really hear the message and are willing to act on it. It has to be provided in language that they will respond to and understand. These days I work in research ethics, and I'm very aware of this when we come to consent forms. It's a very highly skilled task to present complicated, complex concepts in a way that the man in the street will understand. That's not easy to do, and it's not a skill that we necessarily employ a lot in healthcare or that we even acknowledge or recognize. We will need to respect any decisions for non-donation. I can imagine that if that were ever not respected, that there could be quite a bit of backlash. So I think we have to be very careful that we would respect a decision to not be a donor. And I think a big question for us is, what sort of an opt-out system do we want? Do we want what is often referred to as a hard opt-out or a soft opt-out? So if a family says, well, yes, he hadn't signed the opt-out, but we know he didn't want to do this. So what level of evidence do we require in order to respect that? Do we need something in writing? Are we going to legislate this? Is there going to be a common practice across all hospitals, all ICUs, all OPOs in terms of what we accept as substantial evidence that the person really didn't want to do this? And we'll have to manage family expectations, because I think right now the expectation is very much that the family has a lot of control over decisions that are being made. And of course, there's that change from this is a living person with a substitute decision maker, where, as Jennifer said, we are supposed to follow the patient's wishes, but sometimes that gets a little mixed up, and families are not always very clear about that. So this is a person who has now died, and we are going to pursue organ donation, which is a different set of legislation. Spain has told us for many years, Dr. Matissans, who ran the program, been very clear that presumed consent is part of their system, but that their statistics improved for organ donation long before they brought in presumed consent. And he would say, you don't need presumed consent in order to have good organ donation rates. And they do have a little wheel of all the elements that make that up. And I sort of think that that's what we really need to focus on. We've talked about changing the system, looking at the system, examining it, and I think that's very true. So his recipe would be things like chart audits, looking at missed opportunities for identifying a potential donor, for following up when there is a potential donor, for having the resources, and this is a really big one, the doctors, nurses, and ICU beds. We can have all the identified donors we want. If we don't have the beds to house those people and take care of them, then I don't see how this is going to be successful. We also need to put effort into the discussions we have with families around that time of donation, to discuss with them, this is what is likely to happen, the words we use, the approach, whether it's a sort of first-person consent, as has been used in several parts of the United States, where we basically inform people. Our job now is to respect this person's final wishes because they have been registered. And this is what is going to happen. Do you have any questions? Which is very different from what would you like us to do? And I think we need also more engagement of patients and the public, and I think that's one of the hardest things for us to do. We do have a patient engagement strategy right now in healthcare, which has been very fruitful in many areas, but I think we need to take that much further in order for this to get a lot of understanding and uptake within the population. Thank you.
Thank you.
So I'm from Nova Scotia as well, and I'm Steve's partner in crime for our provincial program. And some of the things that we've really considered over time, especially when the government came to us and said, you know, what are your thoughts on this legislative reform, we really did look at it as a piece of a system change. And I think Steve talked about that a little bit, and there was a comment in the audience about looking at it from that lens. And that really is the lens that we're looking at it from in Nova Scotia, is looking at presumed consent as a part of our system level changes. I'm a huge fan of post-colonial theory. In post-colonial theory, you look at the impact of colonization on populations. And when I think about presumed consent in particular from that lens, a lot of what we've heard already this morning from my esteemed panelists, it's about those concepts of power and control. And so you look at how does the impact of colonization on a community or a subgroup impact their power and control. And when we think about presumed consent and the concepts of presumed consent in particular, as it comes to ownership of oneself, this is where I think our approach to things like that Phil mentioned this morning, social engagement, community engagement, those are key to the success of presumed consent as one piece of our system level change. It's really about engaging those communities, understanding what's important to them, and how we can integrate the concept of donation as an altruistic act as an important part of their approach to their end-of-life care. And so from our perspective, I think one of the key pieces that we're really trying to engage in right now is that communications approach with our colleagues at government. In our ideal world, we'd be able to come to you with a run chart in a few years from now, because this is going to be enacted in October 2020 potentially, date TBD, but that's what we're anticipating. In an ideal world, what we'd be able to come to you and say is, this is the point that legislative reform happened. This is the point that donor physicians were implemented in X, Y, and Z hospitals. This is the point that mandatory referral, because that's another key piece to this legislation that hasn't really picked up a lot in media, of course, because presumed consent is the big piece of it. But from a small provincial perspective, and from the tissue and the organ perspective, mandatory referral is a game changer. We've seen that in other jurisdictions nationally here that have implemented it, and we've seen increases in organ and tissue donation over time, mandatory referral being one of those key pieces. So I'd really love to be able to come and say, okay, at this point we did this, and at this point we did this, and at this point we did this, and these are all the differences and changes that you've seen over time. That's what our hope is. That's our ideal world. Of course, what we're trying to do right now is plan to implement all of those things in one giant package, in a year from now. And so I think it'll be challenging to really hit on the point that Steve made earlier. Is presumed consent the game changer, or is it the system level reform? I think it's been really well documented in the literature about some of the impacts of these system-level reforms that we're moving towards, and that they do have positive impacts. Linda just mentioned Spain as a great example. Presumed consent is just one piece of that. They demonstrated that there was a decade of sort of minimal impact of a presumed consent legislation, and then when they introduced more system-level reforms, that's when they've really seen an impact to their donation system. When it comes to a soft versus a hard, and I know Jennifer mentioned this as well, the legislation that's been crafted in Nova Scotia really is on a soft opt-out approach. And that was done specifically looking at how do you integrate the concept of presumed consent over time within a community, within a system, within a culture that is our province of Nova Scotia. And so for us, it'll be things like, and Phil mentioned this as well, it's that languaging piece. How do you change that conversation to an affirmation versus a consent conversation? So those are just some of the pieces that we're looking at from an operational perspective. And donation is donation. And I know Jim from Canadian Blood Services sort of asked about the tissue piece. We are a small province. We're less than 1 million people. So our donation potential is low for organ donation. I think that's only natural in a small population. And so when we're trying to look at the impact of all of our system level reforms, tissue donation is an incredible piece to that puzzle for us because it will demonstrate impact, either positive or negative. And so we're looking at it as a full package, and we're very fortunate that our colleagues in tissue and our colleagues in transplantation are really engaged in seeing this move forward in a positive way. The other thing, and I'll just mention this, Jennifer brought up some of the concepts and concerns related to undocumented or non-resident workers. Again, the legislation in Nova Scotia has a lot of specificity in there about what makes you a resident of Nova Scotia, what enables you to either opt out or opt in. So the registry in Nova Scotia will continue to have an affirmative registry. You'll still be able to determine if you would like to donate some organs and or tissues. And then, of course, you can very clearly identify if you choose to opt out. But there's also very key parameters about what your expectations are from a resident perspective. So it has some definitions in there about who is a resident of Nova Scotia and who can actually opt in or opt out, and likewise who's presumed to be a donor. So my hope, like Steve's, is that we'll come back in a few years and we'll be able to talk about the success that we've had with our system reform, because it's not just a legislative reform in Nova Scotia. It really is looking at that system as a whole. I really, truly hope that our engagement, because I think that is key. We've heard that from Phil already. And when you read through the literature, engagement is the key piece to this puzzle. So it's about engaging patients, families, healthcare professionals in particular. And this is one of the key messages we've had with our colleagues as we're moving forward with this approach. Healthcare professionals are members of the public. They're members of our communities. We're a small community in Nova Scotia. So it is incredibly important for them to understand the benefits of organ donation, and then also how that presumed consent can impact their communities in a positive way.